Welcome back to the channel. In today's lecture, we're exploring one of the most exciting and rapidly evolving areas of orthodontics, clear aligner therapy in teenagers. We'll discuss how aligners compare to traditional braces, how they're planned and used in teens, their benefits, their limitations, and the clinical strategies used to treat Class 2 and Class 3 malocclusions, manage space, correct vertical problems, treat impacted canines, and ensure proper retention. By the end of this episode, you'll have a comprehensive overview of aligner treatment in teens knowledge that's essential for any modern dental professional. Section 1. System Check. First, let's talk about the fundamentals. Aligners can be just as effective as brackets and wires in treating malocclusions in both teens and adults. But not all aligner systems are created equal. A good system must allow force-driven, not just shape-driven movements. It should manage bodily tooth movement, torque, and anti-bowing effects, which are essential in extraction and space management cases. It must support sagittal and vertical corrections, and be open to auxiliaries like buttons, hooks, power arms, and elastics. Compliance indicators are especially useful in teens, since motivation is often less consistent compared to adults. So, before treatment, orthodontists must choose a system that's clinically proven, versatile, and teen-friendly. Section 2. Why aligners for teens? Now, why use aligners in teenagers? First, hygiene. Unlike fixed braces, aligners can be removed for brushing and flossing, helping maintain oral health. Second, enamel health. With rising prevalence of molar incisor hypoplasia, aligners are gentler for compromised enamel. Third, allergies. Since aligners are metal-free, they reduce the risk of nickel allergies. And finally, acceptance. Teens often reject traditional braces because of aesthetics or discomfort. Aligners are comfortable, nearly invisible, and more socially acceptable. This makes them especially powerful for this age group. Section 3. Treatment Strategies Class 2. Malocclusion. Class 2 treatment in teens usually combines growth modification and dentoalveolar correction. The best time is around the pubertal growth spurt. Protocols often involve a two-phase treatment. Phase 1. Use of appliances like headgear, distalizers, or expansion devices. Phase 2. Aligner therapy, which becomes easier and more predictable once Phase 1 has corrected major discrepancies. Aligners can also perform distalization of upper posterior teeth, predictably moving molars up to 4.5 millimeters when paired with elastics and attachments. Elastics remain critical. They can be attached via buttons or precision cuts in aligners. Ideally, Class 2 correction should combine 2-3 molar distalization and 1-4-3 skeletal effect with elastics. Finally, the mandibular advancement feature. Precision wings built into aligners, functions like a twin block, posturing the mandible forward while simultaneously aligning anterior teeth. This reduces treatment time and improves sagittal correction efficiently. Class 3. Malocclusion. For Class 3 cases, treatment is often two-phase. First phase, in pre-adolescence, functional appliances like face masks, chin cups, or traction devices. Second phase, aligners in permanent dentition, sometimes combined with surgery if growth modification isn't sufficient. In early treatment, aligners can act as passive appliances with buttons for elastics, reducing bulk and improving compliance compared to traditional Class 3 devices. In permanent dentition, aligners can distalize lower posterior teeth sequentially, often with elastics for anchorage. Extraction options may include premolars or even a lower incisor, depending on crowding and Bolton discrepancies. So aligners can simplify Class 3 management while improving aesthetics and comfort. Section 4. Space Management. One of the biggest orthodontic challenges is space. If there's excess space, aligners can close diastemas or distalize teeth. If there's a lack of space, there are two main options: non-extraction solutions, expansion, distalization, or controlled proclination. Aligners can do these reliably when attachments are properly used. Extraction solutions, in severe crowding, premolars or lower incisors may be extracted. Aligners then close spaces with the help of auxiliaries like power arms or TADs. Key tip: early extractions in mixed dentition let natural migration reduce gaps before aligner treatment starts, making Phase 2 easier. Section 5. Vertical problems. Open bite. Open bite correction with aligners can be achieved by extruding anterior teeth, intruding posterior teeth, or both. Aligners naturally exert intrusive forces on posterior teeth. Attachments and vertical elastics support anterior extrusion. Combining these movements is often the most efficient way to close an open bite. Deep bite. Deep bite correction involves intrusion of incisors, extrusion of posteriors, or both. Aligners can intrude anterior teeth predictably up to 3 mm, but extrusion is harder. That's why bite ramps are critical. They disclude posterior teeth, allowing extrusion. This is especially effective in teens, where growth assists correction. Bite ramps with elastics make deep bite correction predictable and efficient. Section 6. Impacted canines. Displaced or impacted canines can be treated with different protocols. Two-phase, surgical exposure with auxiliaries first, then aligners later. Three-phase, initial space creation with aligners, then surgical extrusion, then aligners again for finishing. Aligner only, surgical exposure plus elastic attachments directly to aligners. The choice depends on the severity and clinician preference, but aligners provide flexibility in integrating these approaches. Section 7. Interdisciplinary treatments. For complex cases, aligners are most effective when combined with auxiliaries, elastics for sagittal and vertical corrections, TADs for long-distance tooth movement or anchorage, power arms lever arms for uprighting molars or closing extraction spaces, braces or sectional wires as a backup for localized corrections. With digital planning tools, orthodontists can coordinate with prosthodontists, ensuring predictable outcomes for cases involving missing or malformed teeth. Section 8. Retention. No orthodontic treatment is complete without retention. Teens especially need long-term retention since growth can continue altering occlusion. The most logical solution is aligner retainers. Patients are already used to them, and they cover occlusal surfaces to prevent vertical relapse. However, in deep bite or severe transverse cases, a Hawley retainer may be preferred. Many clinicians also place fixed canine-to-canine retainers for anterior stability. Retention must protect alignment as well as sagittal, vertical, and transverse corrections. Conclusion and outro. To conclude, treating teens with aligners requires careful planning, compliance monitoring, and often a hybrid approach with auxiliaries. But the benefits are clear: better hygiene, improved acceptance, and the ability to integrate growth modification with modern digital orthodontics. Clear aligners are no longer just for adults. They're becoming a cornerstone of teen orthodontics. If you found this lecture helpful, hit subscribe, share it with classmates, and check out the next video.